Let me come back now to monoclonal antibodies. We've talked a little bit about daratumumab has really found its home in first relapse in the United States. There was a study presented here which looked at outcomes in people who had previously received lenalidomide and then were going to get daratumumab, lenalidomide, dexamethasone at relapse. Does it worry you? I mean, would you ever use lenalidomide, or are you going straight to POM?
My personal practice is that I do go to POM because if they're lenalidomide refractory, I figure there's going to be a better response rate. However, the addition of the IMiD is really to get that pro-IL-2 effect, and both drugs will do it. I just think you'll have a better and a longer response if you switch to the more potent IMiD.
What about elotuzumab? You mentioned this already, Tom, but what do you think about that, Dr. Rossi?
Well, it's tough, when you have two
This was
monoclonals.
The Optimism trial, is that correct? Am I getting the right trial?
Eloquent 3.
Eloquent 3.
Was with
The elotuzumab, pomalidomide.
Yeah.
Yeah.
That's Eloquent 3?
Eloquent
Okay, well, keep me straight.
So much
trials.
data. It's
So what did you
another
think
good
of that?
problem to have.
Eloquent 3 was published in the New England Journal of Medicine last month.
I think it's a good combination. I think daratumumab sort of becomes everyone's favorite monoclonal, but we have to remember that we do have an option. And if we are moving daratumumab up front, having say a Dara RD up front, then the Elo POM allows you for a completely new triplet.
Is there daratumumab resistance, Faith? Can you retreat with daratumumab?
Oh, I was going to say, my brain was like, yes, you can definitely retreat with daratumumab.
Do you think it works, even if you've failed it before? Or?
Yeah, I think that as with all drugs, there's nuances as to how long and what amount of space you need between your between retreating and so on. But yeah, no, I've had plenty of experience of having good responses.
I mean, I was struck by our lymphoma colleagues who just rituximab everywhere, even if they've had it before and progressed. But Raphael, are you seeing any daratumumab resistance? And if so,
Clinically, you can see it, and particularly, I think when you run into trouble with the combinations, but even with the combinations, you do see resistance. So I have patients who responded for some time to Dara PD, the daratumumab, pomalidomide, dexamethasone, and then progressed through that. So we do see that. I think your point is well taken. Does it add? It probably adds, just like in lymphoma that is used with different regimens. Of course, we're going to have other antibodies too, and other CD38 that were presented.
what about elotuzumab in those patients who you're seeing resistance? Is that something you're excited about?
It's a very important question. The New England Journal of Medicine paper does show that nearly doubling of the response rate, PFS. However, only a very small fraction of those patients had daratumumab exposure. It was, I believe, it's in the range of 2%. That's a critical question. Now, POM works well, but POM has to be combined, particularly in that setting. And there's a previous study in combination with cyclophosphamide from the Moffitt group, the Optimism study in combination with bortezomib. But we need to have that option for patients who are relapsing post-standard, second-line therapy.